Thank you very much for the kind introduction. Thank you very much for inviting me to give this talk. We're coming now from 250 MeV, maybe back to 5 MeV, and a completely different way of treatment or treating patients. So my talk will be focused on targeted alpha particle therapy. That is a new treatment modality that comes up, and I will talk on imaging, dosimetry, radiation protection. I'm trying to cover all these issues. So if we look at targeted therapy in comparison to, where's the beamer here, to conventional therapy, conventional nuclear medicine therapy uses beta particles. You have a range of 800 to 5,000 micrometer. You have an LET of about 0.8 kV per micrometer. That changes a bit depending on the energy of the particles, of course. Whereas for the alpha particles, you have a much shorter range, 40 to 90 micrometer, and LET of about 100 kV per micrometer. That means you deposit a lot of energy in a very short range. Shown here is what you aim at. You have a tumor, you have some kind of ligand that binds to the tumor here, either with a beta particle or with the alpha particle. And now the art is to hit the tumor with the particles. So with the beta particles, it's a bit easier because you create a homogeneous field, whereas for the alpha particles, you need really to hit the tumor. And this is shown in the next slide. That shows that, for example, for 10 milligray gamma photons, you have about 550 electron tracks per cell on average. Whereas with the alpha spectrum, you have a complete dose spectrum from 0 to 0.30 gray, and not all the alphas hit the cells that you want to hit. So that is really art to find the right combination for treating the patients with the alpha particles because of this short range. You can also visualize the DNA damage caused by alpha particles. Here is an example. It's a human lymphocyte crossed by a radium alpha particle, and you can see the track, so to speak. So it's nice. Many people show the Monte Carlo simulations, but I think it's also interesting to see this in vivo, that you can really show the effect of alpha particles in a cell. And here, this here is hit by an electron. So you have only single hits if you look at those foci. Also, you can show that you do some damage with your alpha therapy. That is a historic example. In Germany, there was a treatment until the early 2000s, treatment of ankylosing spondylitis with radium-224, which has been discontinued then because of the late side effects in those patients, because this was treating a benign disease, and so you observed a lot of secondary cancer in those patients, even though you administered only activities of around 10 megabecs. And here in this work by Stefan et al. From Munich, it's nicely shown that you have an increase of the dicentrics per cell as a function of the absorbed dose to the blood in those patients. So that means you have really late effects, although you administer only 10 megabecquerels. So what are the alpha-emitting isotopes for therapeutic applications in nuclear medicine these days? The list is not complete, but those are the ones that I found in a lot of or in some publications now, and also depends on availability. So we have astatine-211 with a half-life of 7.2 hours, bismuth-213 with 46 minutes, which is a generator product, radium-223 with 11 days, and actinium-225 with 10 days half-life. So you have a wide spectrum here of half-lives, and particularly for bismuth, you have the problem that because of the short half-life, you have to find the right ligand to combine it, because otherwise, if your biological process is much slower than the decay rate of the half-life of the drug you're using, the drug will disappear before the isotope will disappear before the drug is delivered to the target. So that is really critical for the bismuth. On the other hand, you have a very high dose rate here because of the short half-life. So what kind of treatments can we foresee in nuclear medicine? We have several classes of treatments. For example, we could use metabolic active radiopharmaceuticals. Those are very simple molecules. There have been in vitro studies with astatine-211 on substituting iodine, more or less, for thyroid diseases. that also looked nice. And it's a very simple molecule. The same is, and I will focus later in my talk on that, is radium-223. Radium-223 is used as a dichloride, so it's a simple salt. And so there's not much labeling, and it's metabolic active in this case. Then the second class are specifically binding radiopharmaceuticals. For example, you have radiopeptide therapy, which addresses specific antigens or receptors, or PSMA. That's the other therapy that is being discussed at the moment. But here you have two problems. First of all, or two issues. You have to label your active compound to the antigen or to the receptor binding a ligand. And that is a problem because you can get radiolysis, for example, and also you have to do this on-site. That means that you have to do some more chemistry in your lab. Usually, normally, nowadays, at least in most European countries, you have to use GMP facilities for doing that, and GMP with alphas is sort of a challenge. But it's possible, and it's done in a few sites. Also, the availability of those two compounds at the moment is limited. And an old example was a treatment of lymphoma with antibodies. Also, this is a large molecule, and also you have the labeling process. It binds well, but the process of getting it to the place where you want to have it is cumbersome. And last but not least, in nuclear medicine, we have also local regional therapies, selective internal radiotherapy of liver cancer or metastases of liver cancer. And also for those, alpha emitters are possible options and are being discussed. But for the rest of my talk, I will focus now on radium. Here you see Madame Curie in her lab, because this radium is the only isotope at the moment that has a marketing authorization and is manufactured on a large scale and also distributed on a large scale throughout, more or less worldwide. So this is the data set that finally led to the marketing authorization. Here it was a phase 3 trial here. The green one is the data showing the overall survival in the patient group with radium-223 compared to placebo. And it's used in metastatic prostate cancer treatment. So you see that you have a median increase of the survival of around 3 months, which is for cancer. You might think it's not very much, but for cancer treatment, this is a lot, actually. If you look at the new drugs, all the antibodies that are being released, they are in the same range of increasing the survival of patients. So radium-223, here in those around 900 patients, worked quite well, and that was a reason why now we have the so-called, it's called Xofigo, and the drug is available now for treatment on treating patients and is being distributed throughout the US and Europe and partly worldwide, I think. I'm not sure about the list of the countries, actually. Sorry, that was the wrong direction. So, but radium-223, it doesn't come as a isolated isotope, but you have a complete decay chain here of different isotopes. This branching ratio and this branching ratio is very low, so we don't need to consider that. So it goes into radon. We have polonium, lead-211, bismuth-211, and then we have two branching ratios. 99% goes into thallium, and only 0.3% goes into polonium-211. So, but you have to consider all these progeny, all these decay products, if you want to do dosimetry and want to see how the effects are. It's not as simple as just using a simple beta emitter. So let's look at the decay of radium-223 in more detail. Here we have again the branching ratios, and here we have the half-lives of the different compounds. The good thing is that you have a long half-life of radium-223. That means you get an equilibrium rather fast of all the daughter products. But bear in mind we have radium chloride, or radium dichloride actually. But what happens if the radium decays to radon-219? It's no longer radon dichloride, it's radon. It's a rare gas and could diffuse from the side. So the short half-life here ascertains that once it is binded, at least, the diffusion process in the bone, because it goes particularly into the bone, will be slower than the decay here. And so you can build up all the alphas here. And if you look at the change of alphas here and sum up, you end up with around 29 MeV total energy released. And of course, you hope that everything stays close or near the tumor and releases all the energy. But this has not been proven yet, and it's very difficult to see that. We know that there's some diffusion of the radon, and the rest more or less does not diffuse quite well, but anyway. Also, I would draw your attention to this column here. So for two decay products, lead-211 and thallium-207, you have a high, this is the energy released by beta and Auger electrons. You have a higher energy that is released by that, and that plays a role for radiation protection here, because those are beta emitters, particularly with some higher energies of beta particles, and those need to be taken into account when you go for radiation protection. So we want to do some imaging, as I said, because imaging is one part of the dosimetry that we need for nuclear medicine therapy. And if you compare the spectrum here, that's a nice spectrum we took in our germanium detector. Here you see distinct peaks, gamma peaks in the spectroscopy, and here I matched the spectrum published by the Royal Marsden Group for one gamma camera, and you see quite a difference. Here those peaks are almost undistinguishable, and only this peak brings a lot of counts actually in order to see that. And you have a lot of scattered radiation here. All these contributions are scattered contributions from higher energy photons. That means that the images will not look very good. Why is this the case? A short detour showing you how a gamma camera works in a few steps. Here you have a slice. This is a thyroid of a patient. You have a slice, transfer slice, and you have a photon. Here you have a collimator that determines the direction, and here you have a sodium iodide crystal. And here's the light emitted, and here's the amplification, and you get the sum and the energy information, and of course the spatial information by taking the center of gravity of the emission. And with that, you get your counts here, and what you do at the end, you get a two-dimensional image of a three-dimensional activity distribution. Here in this patient, you have scatter, you have attenuation, everything, and you see something, of course, but what you see is not quantitative at the moment. And so the quantification of planar images is quite difficult, and it's even more difficult if you have low-quality images. How a modern gamma camera looks like is shown in this slide, courtesy of a German company. Here, usually, this is a SPECT-CT system, and here you have the patient bed, and you have here the CT system, and here you have the the heads of the gamma camera. The collimator is here, the crystal is here, here are the photomultipliers, and the electronics is somewhere else in the room. So, but you have to use this equipment. Resolution is about 0.8 centimeter, spatial resolution to 1 centimeter, particularly depending on the collimator you use. And so that's not very good. And that explains, here again you see the spectrum, why the images here look like this. So here in these images, take sequential images taken by the Royal Marsden Group for the clinical first, I think, phase 2 trial. You see at different time points after administration, and you see here, first of all, you see that the activity stays or is excreted mainly through the intestines. That's one point. The second, you see here the metastasis in this patient that takes up, which is good for the patient, and you can see it even after 144 hours. But you also see that you have a lot of scatter here, and this is all scattered radiation, and that makes the quantification really a challenge. And quantification is one of the things you need for a quantitative imaging, you need for dosimetry in nuclear medicine. Here's another example taken from the phase 1 trial at the Sloan Kettering. Again, these are just static images, not over the abdomen, and here you see again that the activity goes through the bowel and is excreted. Well, you can partly see it here, at least at the end. Here, for example, here's a bone scan that is done with technetium-99m MDP as a comparison, also to see if the target really takes up the radium. What you also have, because we're talking about biodistribution now, is that you have a huge variability of the biodistribution and the whole body clearance in the patients. This is the decay also taken from the Sloan Kettering data. This is the decay corrected whole body clearance. That means the physical half-life is taken out. And you see in some patients the activity stays more or less over 150 hours and more. And in some patients they have a very fast clearance. So that makes also the comparison and dosimetry quite a challenge, because you don't have a very uniform distribution. And some other treatments that we're having in nuclear medicine at the moment, the distribution of the biokinetics is more uniform or less variable than in this case. Now, we talked about biodistribution. Now we're coming to dosimetry. And in dosimetry, we face another challenge, particularly for alpha particles. Usually, for betas, we use high activities. In nuclear medicine therapy with alphas, it's in the range of 10 to 15 megabecs. But we have a combination of deterministic and stochastic risk, damage and stochastic risk. We have to bear that in mind. Also, when we want to calculate somehow the effect to the RBE or whatever, it is not so simple as it seems. But we want to have patient-specific dosimetry. At the moment, what we're doing is more or less for the radium treatment, model-based dosimetry, because the activity is administered in becquerel or megabecquerel per kilogram, patient weight. And particularly for radium therapy, is the paradigm. What we want to do, the maximize tumor absorbed doses and minimize the absorbed dose to the organs at risk, is not doable at the moment. So we have a mixed, so to speak, for radium. We have a mixed. We start out here and then we go more or less. Well, we don't optimize image quality, but we're trying to minimize radiation-associated risk. But this is not done on a patient-specific basis at the moment. Why is that? Because in internal dosimetry in nuclear medicine, you distribute your radiopharmaceutical throughout the body, and the biokinetics is determined by physical and chemical properties of the radiopharmaceuticals, of course. And you have source organs and you have target organs, and the source organs irradiate the target organs here, and at this example. And also you have your biological variability. So one way to calculate this has been devised in the 1970s by the MERT Committee of the American Society of Nuclear Medicine, and it's a so-called MERT scheme. And that means that you can break down the absorbed dose calculation in two parts. One part is taking into account the biokinetics, of course, and the administered activity as a parameter, and the biokinetics integrate over time to get all the decays in one organ, and multiply this with a corresponding dose factor. This works on an organ level, but also could work on a cellular level. To show this in more detail, here's the simplified equation. You have the dose is the absorbed dose rate per unit activity. The so-called S factor, this describes the physics and the geometry. And here the number of decays and time integrated activity coefficient, that's the term. But what you do is you determine your time activity curve over time and try to quantify this. And with beta emitters or combined beta gamma emitters, we can do this with SPECT-CT systems quite well, not quite well, but with a fairly decent accuracy. But at the moment, we only have for radium therapies only planar images, as I showed before. So to get this curve is quite cumbersome, and to get this accurate is even more cumbersome. Here, because we need this. The shaded area here will give us the number of decays in the organs. So a group in Italy did work on metastases. It did some planar imaging on try to quantify this, did a multi-center trial, and tried to get everything right and the quantification right. But again, you see here a lot of scatter in the data, and scanned the patients over 404 hours and could obtain some nice data on tumor absorbed doses here. And those is shown their relative activity as a function of time, and the mean absorbed dose after the first injection of the patient was 0.7 gray, and the RBE weighted doses, the weighting factor is 5, was about 19 gray to the tumor, which is a fairly good dose if we believe the RBE of 5. To get the dose for the normal organs and tissues, Dietmar Noske and I did some calculations a few years ago using the ICRP model 67 modified for injection with the different compounds here, skeleton, soft tissues and intestines, and calculated the corresponding absorbed doses. And what you could see here is that the red marrow and the bone endosteum show the highest absorbed doses, gray per becquerel here. All the daughter products were taken into account. So if you administer 21, normally we have 6 treatments for radium treatment for a 70 kilo person, and the activity is 50 kilobecquerel, 55 nowadays kilobecquerel per kilogram. You end up with a bone endosteum with an alpha dose. This is really an absorbed dose of 16 gray, and the absorbed dose to the red bone marrow is about 1.5 gray. So also that shows that we have 2 organs at risk, so to speak. That's the bone marrow. We see some toxicity in some of the patients, not very many, and also the bone is a target because the radium chloride goes to the bone, and that's the normal bone. Gets fairly high doses. Metastases get even higher doses, as I've shown before. Also, the interesting fact is, and we have to work on that, what to do with the weighting factor, with the RBE, because we have a mixed field, so the factor of 20 most likely is not applicable maybe to normal organs. Usually we use a factor with alpha therapies, a factor of 5 taken from biological experiments, but that is a factor of 5. The hard evidence is not there. Usually you see in many experiments a factor of 3 to 5 efficacy. But what do you do in mixed organs when you are somehow in between radiation protection and deterministic effects? That is an open question, and I cannot address this, and clearly I don't have a right answer at the moment on that. Another thing is that, because I showed the activity in the intestines, but in this case most of the contribution comes from the beta emitters, from the daughter products, because the alphas are effectively shielded within the intestines. Okay, coming back to changing topic a little bit, radiation protection. There are also not many publications around that give some reliable data. One also comes from Sloan Kettering, from the Sloan Kettering group, and they were taking the data from the first phase 1 trial they had. Interesting thing is that most of the contamination detectors you have sufficient efficiencies for wipe counting. Here you have an alpha probe compared to a thin window beta gamma probe, and here you see that the minimum detector activity is around factor of 5 higher, but still works. Maybe the low energy gamma probe is not so well suited. But again, if you go to liquid scintillation counters and gamma counters, also those devices are well applicable for monitoring wipes. If you think about the dose rate of the patient, and here's some data normalized to the administered activity, we know that we have about 4 to 5 megabecquerel per, so you have to multiply this by a factor of 5 for a real patient. But then you see that the external dose rate here is at 30 centimeter distance, for example, is really rather low. It's microsievert, it's here if you multiply this by 5, it's 0.6 microsievert per hour. So again, the external radiation doesn't play a major role. Next question could be excretion and contamination. And that was an abstract published a few years ago at the SNMMI Congress by the group from Hanover, Germany, and what they measured, they looked for radium-223 in saliva, so its median value was 22 becquerel per gram, so it's not very high actually. You find some activity in the sweat, but also that's negligible. Also, they looked at the contaminations in restroom and kitchens of the patients at home after treatment, and also the levels were really extremely low. And also they measured the inhalation of Radium-219 because that could be a potential concern. Staying in a room with a patient, and it's also the contribution is rather low. The only thing that has been recommended by the German radiation protection authorities is to start with, because of the high beta component, to start with extremity surveillance if you have more than around 25 to 30 patients a year for a single person. That could be an issue, and that monitoring, at least in this case, doesn't hurt. For the rest, the absorbed doses are rather low. So to conclude my talk, administering alpha emitters opens a promising path to a new treatment option for molecular targeted therapies. There's some very good data on efficacy for prostate cancer patients with actinium-labeled PSMA, but this is at the moment still at the experimental level. Radium-223 dichloride shows a benefit in survival of the patient. However, it's administered on a per kilogram basis, and dosimetry doesn't play a role, frankly speaking. You see, I showed some slides that the biodistribution in patients, the quantitative measurement of biodistribution in patients is challenging because the activities are very low, as I said, and you have low emission probabilities of the photon energies. And also, for normal organs and tissue, at the moment, we rely on the compartment modeling based on the ICRP-based compartment modeling, which should be replaced by more patient-specific calculations, but it's work in progress. I think some groups are working on that. Of course, we have the systemic treatment and what we do with the RBE between alphas and betas. We have to think about that. This is also matter of discussion and matter of research. And for radiation protection, most of the measures that are used for normal nuclear medicine departments are sufficient also for alpha treatment because the activities are low and the sensitivities of the devices are quite high. You only have to think about what happens if the patient numbers handled by a single person exceed 25 or 30 patients per year, of course, not per day. Thank you very much for your attention.